Looking at the psychological aspects, which are mostly invisible, and unless we actually go in and look at what people are experiencing and feeling, we may never know, right? So typically what is happening is like what you're seeing on the screen, right? That there are so many of these thoughts and feelings and beliefs, right? And experiences that patients and their family members are having, which never come to the forefront unless we really go in and talk about it, right? So for example, one of the quotes here says, bad enough that it is cancer, now this pain. Even when I try to focus on something else, it keeps coming back to my mind. It feels like my body and mind are tired all the time, right? So this is just one experience that, might be coming out. We also have family members who are also equally fused with the patient, right? Who's experiencing this. And things like, he used to be so active, but now even small movements cause him so much pain. Watching that every day breaks our heart. We feel helpless seeing him suffer. So we need to understand that this cannot be something that we look at in isolation, that only the patient experiences, right? So over the course of the next 15 to 20 minutes, which I have, I'm going to be taking you through specifically what psychological aspects are with regard to chronic pain in cancer. So what we typically see is the tip of the iceberg, right? We really see only what comes into our mind, but we do not, or what we observe in terms of the non-verbal. So unless somebody really gets upset, cries, get angry, only then do we start thinking, okay, is there something more to it than just the physical part of the pain? Now obviously there are multiple definitions, and we're looking at what acute pain is, what chronic pain is, but cancer related or chronic cancer related pain is caused by the primary cancer itself. It could be as a result of the metastasis, or it could be as a result of the cancer treatment, right? So it could be as a result of them undergoing treatment, they are experiencing some amount of pain. So what do we not see, right? Everything that is underneath, right? Most of the time we are oblivious to these things, right? And either we will say we don't have enough time, and so we brush it off. But the same patient, the same family will come back to you multiple times. And at that point we will start labeling them, saying that they're annoying. They keep asking these 1,000 questions. They're asking, when is my pain going to end? They have cancer, of course their pain is not going to end. Right? And we usually dismiss these things, right? So it's very essential to know that there are a million things that are under the surface, which needs a person, a trained physician, who is able to spend that 1-2 extra minutes to try and at least give them that chance and that space to talk. So like Sir was mentioning in the morning about how cancer pain has now become biopsychosocial, this cannot be something that we still continue to do, right? Because this is again looking at only one aspect, and like he talked about total pain, right? We now have to look at this as a biopsychosocial spiritual model, wherein we consider all facets of what this person is undergoing, right? And we need to understand that it's a interplay between all of these aspects of a individual's life. Specifically, when we look at the mechanisms that link the mind and pain, we're looking at one where catastrophizing, right, or rumination about constantly having thoughts about pain, about understanding why is this happening, nothing that I'm doing is making any difference, right? It magnifies the pain experience that people have. It also leads to a lot of helplessness and also worthlessness, that what is the point in doing all of these things if nothing is going to change the outcome? And that results in increased distress and psychological suffering, and definitely impacts the quality of life. Fear, avoidance, helplessness, and social isolation. As a result of this, people start avoidance behaviors, right? They may not come back to your OPD even, right? They may go on doctor shopping to find other places or other people, and that's where probably cannabinoids become one of those things that they go in a desperate attempt to find some way to get relief, right? They also do not show up to social functions. They don't want to be seen sitting crooked, crony, or not in their best self when they show up in a public space. And given that we are such a cultural society, we are very sure that one small change in the way you look will attract 101 questions. So imagine being in physical suffering and going and showing up into a social gathering. So withdrawal, and this again obviously leads to amplification of the psychological distress. The last one being the neurobiological mechanisms, where definitely organically that there are links between pain and emotions. We're looking at the mechanisms that regulate pain perceptions, and this is again intertwined with emotional suffering. So this finally leads or ends up in what we understand as the psychological impact. So this could be resulting in depression, anxiety, uncertainty about the illness and what is going to happen, right? The prognosis, fear that this pain might just come back up because we are not really sure about, when this is going to end, when there is a chronicity involved in it, and feelings of hopelessness or catastrophizing, right? So why is this patients, or why do patients get stuck in this vicious cycle? Because it starts with the belief system. If the physician or the people who they go to are unable to try and make sense of it, right, from the physical point of view, of course the belief system is going to go into saying that, hey, maybe there is actually no way that I'm going to get out of this, right? So the feelings and emotions that are associated with it then goes into what we call as behaviors. And once these behaviors come into play, then they become kind of patterns, right? So these are things that they're going to continuously go back to because there is no good outcome that is coming out of it. And finally, the consequences of it, right? So if there is a physician or there is a team that is helping them get through it, then maybe, yes, they feel hopeful, they feel like something is being done for them. But if that is not happening in reality, then this vicious cycle continues to happen. Another very interesting thing that I read from the study, which talked about how when we look at pain, especially in cancer, where acute pain tells people about how vulnerable they are, right? I'm sure all of us have experienced pain at some point in time in our lives, and we know that that is the one thing that makes us realize that, there could be danger to ourselves internally, right? The second thing is when chronic pain takes place, there is this experience of the temporality of being a person, right? This is the time period where we have so much uncertainty. We do not know when this is going to get better, right? And when we say chronic pain, for us, maybe as healthcare professionals, it's okay to use the term, but for a patient or their family member, chronic pain can be extremely debilitating. The last one, I think, is what is of most relevance, which is that cancer pain itself creates confusion or creates thoughts about mortality. Am I going to die like this, right? Because I have cancer, is this what I am supposed to experience, right? So the definite impact that one experiences as a person or in their existence is something that comes in when a person is experiencing cancer pain. So where do we go from here, right? The assessment. Remember that not all psychological factors are psychiatric illnesses. I'm sure Dr. Pavitra will agree with me about that. That this is something that people very quickly label. The minute somebody cries, the minute somebody feels low, they jump in and say, oh, they're depressed, right? But do we really think they're depressed? Do they have all the criteria that tells us that they are depressed? No, right? So this superficial labeling, and today sadness is also called as depression, right? So we use these terms so loosely. So we need to be very careful that if it is psychological, then is it their mood? Is it their cognition or their thoughts that are happening that are causing them to feel low? Or is there some other deep underlying issue that needs to be looked at and addressed? We also have to look at psychological factors, determining who develops this, because remember, they were not born that day, right? They have a past, right? They have a personality, they have other characteristics that define how they cope, who they were like before this disease came in or before this pain came in. So we need to try and respond to that very, very, tailor make our approaches to help them. And so comprehensive understanding becomes very, very important. So these guidelines, which came up as a result of the Indian Society for the Study of Pain, and we have some of our eminent faculty here who have been a big part of this, right, talked about what exactly is comprehensive pain assessment. So yes, physical manifestation of pain, interference of pain with their daily activities of life, but also looking at the psychological factors, right? We are also going to be looking at fear, effect on their personalities, on their interpersonal relationships, and lastly, their spiritual aspects. So when we look at the specific psychosocial spiritual aspects, we are going to start by understanding what are their beliefs about pain, right? Do they think this pain is going to be there forever, right? What are their thoughts? What is really going on in their mind about this pain? And have they had any past psychiatric history or any kind of other history that we are failing to elicit? Looking at, like I said, their coping skills, their history with substance use or abuse, risk of opioid misuse, and lastly about, because we are from a culture where religion, spirituality and our culture play a very integrated role in our lives, we need to make sure that we are looking at these factors. So what are some of the evidence-based tools that are available? One, obviously looking at pain being the fifth vital sign, where you could use a visual analog scale and rate the pain that they're experiencing, but also going one step further and associating with the sixth vital sign, which is distress, which is very, very important in cancer, and using the NCCN's distress screening, which is freely available to use online. Today we also have an Indian validated total pain scale, which has 18 items, which helps us to look at pain through a multifaceted lens. The patient health questionnaire, which is primarily used for depression, and the generalized anxiety disorder, which is a very short 7-item tool which helps us identify if anxiety could be present. And pain catastrophizing scale is also something that can be used. But out of the lot, in your clinical settings, this is the tool that could be coming in handy, which is a brief screening tool which is called as ACT UP, which typically looks at how you ask questions in your clinical interviews about how the pain is affecting your life based on their activities. C for coping, right? How they deal with the pain, what do they really do, when does it really get better or worse based on what they do. Think about, do you think this pain will ever get better? So that will also tell you about the catastrophizing aspect. Upset, because this we never ask, right? How upset have you been or worried have you been because this pain is something that is affecting you? And the last being about the people, right? How are the people around you responding to this, right? Are they also catastrophizing along with you? Or are they sitting quietly and ignoring you and saying, oh, they're so attention seeking, this is what they do all the time, they've done this before, now they're doing it when they've got diagnosed, right? So be very certain to know that this screening tool can really help with that. So when we come to, once we have assessed, then we move into triaging, because everybody might seem like they need your support and care, but it might not be physically possible for us to do these things. So be very clear that everybody who is involved in looking after patients need to be able to manage mild distress, right? So it is the duty of each and every physician or nurse or whoever it is that the patient is interacting with to manage mild amount of distress, and this is something wherein you need to learn the skills to be able to do that. You also have the need to escalate it to a mental health professional if the distress levels go beyond moderate and severe or are in extreme in nature. So this could mean a psychologist, a psychiatrist or a social worker who is trained and who knows what could be done or can be done to help them. So triaging, like I said, should be very personalized, and it should take into consideration the needs and look at what are the local resources that are available in case we need to refer them out as well. Coming to the most talked about word of the day, I think has been CBT, right? Wherein when we look at psychological interventions in cancer pain management, yes, from the West, CBT works great, but in reality, when you come into a clinical setting and ask us to do CBT, trust me, patients are looking at you blank, right? This diagram looks great about how thoughts, beliefs and behaviors and emotions are integrated, and they are, but is this something that our patient population is tuned to? Not so easy to do, right? So we need to try and tailor make and put these things out based on what their preferences are, and not, one size does not fit all. Not everybody is going to get better with CBT. I'm sure even in your regular psychiatric settings, this is something that you cannot consider as well. The much more newer, much more integrative ways of doing it is through mindfulness-based therapies and relaxation techniques, which have been of much better use, where patients and families are willing to go down that route when you mix the two, right? So you are able to help them bring more awareness about what they're experiencing and try and find ways on how they can handle their stress. newer therapies that have come in is called as acceptance and commitment therapies that try and not focus on avoidance, right, where we try and say that this is going to happen, how are we going to handle it, right, and use a much more practical based approach to try and deal with the concerns that they experience. One of the things that I have used specifically is meaning-centered psychotherapy, and though again it has developed from the West, it has created a much more easier plus an integrated way for patients to make meaning of the suffering that they're experiencing. So helping them do some specific exercises through the meaning-centered therapies, manual has helped to kind of make sense of, what they're experiencing, not just about the pain, but also other aspects of their life. And this is something that can be done in both individual as well as group settings. So, I should have started with this slide, but I thought I will end with this slide. But why is it that patients don't seek help, right? Despite all of this that we want to help them with or support them with. Because most of the time pain management is focused on the pain and not the person, right? Tolerating pain in silence, because most of the time they see you as clinicians or physicians running around doing so many things, and they don't want to bother you with their psychological states, right? And they also feel like, oh my God, I'll waste my physician's time, right? So I don't want to be a burden on them. Some people don't believe that pain medications work, or allopathy is not going to do anything for me, though they might be on chemotherapy and they detest it completely. We need to understand that patients' preferences about their types of, orientation towards medical systems also could be very, very different, and that is where educating them about pain management, educating them about this condition or the process that they are experiencing is something that's very important. Also looking at the feelings of uncertainty because of their worsening emotional distress, the lack of social support, and lastly, language and cultural barriers definitely are a big part that also makes them not want to seek support. So to conclude, psychological factors definitely shape pain experiences and outcomes, but pain is not felt, but it is interpreted, and spiritual beliefs can transform the experience from suffering to meaning making. Social isolation and fears about mortality obviously worsen the pain intensity, and hence some community support and existential care needs to be incorporated into the clinical situations or scenarios. Some amount of screening and basic psychological interventions is something I think we will all benefit from learning, and this is something that you can adapt into your clinical practice along with having a counselor or a psychologist being a part of the multidisciplinary team. And the last one I leave you to reflect on, which is about how will you change your approach to managing chronic pain after you have been part of this entire CME. So thank you.